get straight to the heart of things. You are seeing Mr. Inchliziyo, a 27-year-old former IV drug user, but he's now being clean for the last 5 years and is doing very well with abstinence. But he is coming in with the clinical problem of dyspnea. His examination suggests severe mitral regurgitation, and this is confirmed on your echo. His left ventricular systolic function is normal, and the consulting cardiothoracic surgeon feels that either mitral valve repair or replacement are both technically feasible. His blood pressure is normal. Now, which of the following is the best course of therapy for Mr. Inchliziyo at this time? Is it A, initiating enalapril 10 mg daily? B, no therapy now, repeat echo in 1 year? Is it C, surgical mitral valve repair? D, surgical mitral valve replacement? Or is it E, a transcatheter mitral valve repair? Let's get stuck in, guys. So first and foremost, how do you detect that a patient has prosthetic valves clinically? Well, the following ways. Firstly, you may see a vertical mid-sternal scar mark of thoracotomy on the precordium. That's a big seller that the patient had some surgical intervention before. Then, in metallic mitral valve replacement, there is indeed a metallic sound on auscultation. We call them the so-called valve clicks. In tissue valve prosthesis, there will be no metallic or plopping sound. Rather, there is a click. All right. So how do we detect clinically whether the replaced valve is mitral or aortic? Good question to ask this morning. So mitral valve prosthesis is detected by, when you're auscultating over that mitral valve, there's a metallic sound that coincides with the first heart sound, like lup, dup, lup, dup, lup, dup, which indicates sharp closing. There's a normal second heart sound. You may also hear a diastolic flow murmur, which is a mid-diastolic murmur normally, and the sharp opening or closing sound or click that coincides with the carotid pulse, right? Versus the aortic valve prosthesis, and you know this because when you listen over the aortic valve, which is in the right second interspace, a metallic sound is present which coincides with the second heart sound, lup, dup, which indicates sharp closing. And the first heart sound is normal. An injection systolic murmur may be present normally. The sharp opening or closing sound or click that occurs shortly after the carotid pulse, that indicates an aortic valve prosthesis. So what are the different types of prosthetic valves we get, everybody? By and large, there's two types, metallic valves and then there's tissue valves. So the metallic valves, they come in different flavors, right? The Starr-Edwards valve, which is an example of a ball and cage valve. The Bjork-Shiley, which is a tilting disc valve, and the St. Jude's, which is a bileaflet double tilting disc. Versus the tissue valves, examples are the Carpentier Edwards valve and the Hancock porcine valve. So here's some illustrations that we can see. Typically, we have the caged ball valve. Here's an illustration. The tilting disc valve and a single leaflet valve, and here's the bileaflet valve, right? Here's an example of a porcine or a bovine valve. Just some information on tissue valves, guys. Regarding these, they can be either one of three types: a xenograft, a homograft, or an autograft. Now, a xenograft is made from porcine valve or bovine pericardium. Porcine implies pig, bovine implies cow, so and moo. These are somewhat less durable and may require replacement after 5 to 10 years. So that's the drawback with the xenografts, and anticoagulation is not required. But in the homograft, these are cadaveric grafts, right, which can be derived from either aortic or pulmonary human valve. It's particularly useful among young patients and in replacement of infected valves. An autograft is valve replacement from the same patient, that is, from the pulmonary to the aortic valve position. So how do we determine if a mitral prosthesis is leaking? Well, you will hear that beloved pansystolic murmur, which indicates leaking. A mid-diastolic murmur may also normally be present, and any systolic murmur of loud intensity, as we know, is a sign of failure. Now, ball and cage valves project into the left ventricle itself. It can cause low-intensity ejection systolic murmur. Doesn't necessarily mean that that valve is leaking. Tissue valves and bileaflet valves can also have a low-intensity diastolic murmur. If your aortic prosthesis is leaking, how are you going to detect this? Well, the presence of an early diastolic murmur indicates leaking, and ejection systolic murmur may be present normally, as all types of valves produce some degree of outflow tract obstruction. When it comes to the tilting single disc, that's your Bjork-Shiley, and your bileaflet, that's your St. Jude's, these, as we know, do not completely close and allows for a regurgitant stream during diastole. So there may actually be a low-intensity diastolic murmur with these. The intensity of this murmur increases as the valve progressively fails. Now, the ball and cage valves, like the Starr Edwards and the tissue valves, do not close completely and diastole, and so any diastolic murmur implies a valve failure. Okay, what are the different advantages and disadvantages of the different kinds of valves we have available? So regarding the metallic valves, the big selling point of these is that the incidence of valve failure is less. So the metallic valve is more durable. But the drawback or the disadvantage is that incidence of thrombosis is high, so therefore you require anticoagulation, especially with warfarin, which mandates you coming in for your monthly INR checks. And of course, metallic valves can cause microangiopathic hemolytic anemia. Prosthetic valves, the big advantage there is that the incidence of thrombosis is less and you don't require anticoagulation, so you don't require the monthly INR, and there's no hemolysis. But the disadvantage here is that the incidence of valve failure is high due to stiffening and tearing of the valve leaflets, especially over a duration of 10 years. So therefore, these prosthetic valves are somewhat less durable. It lends itself to degeneration and calcification in the long term. Complications of prosthetic valves. Guys, let's go. Thromboembolism first up, and we spoke about this more in the metallic valves, more in the mitral metallic valve than the aortic metallic valve. And we said anticoagulation is necessary, and you want to maintain that INR generally between 3 and 4.5. Now, you've got to tell the patient you've got to come in monthly for INR checks, at least. Right? The second thing is primary valve failure, which is probably more common among the tissue valve than metallic valve. Sorry about this. Right? Because we said that the tissue valve is less durable than the metallic valve. Okay, valve leaking, and then there's dehiscence or detachment of the valve from the site of the valve ring. The valve can become obstructed by thrombosis or calcification. What about microangiopathic hemolytic anemia, mainly an aortic valve of over 10 years duration, and occurs in about 10 to 20% of these. Regarding the tissue valve, there may be calcium deposition, which long-term leads to perforation, rupture, and degenerative changes. Another problem is infective endocarditis, especially during dental procedures, during catheterization, right? That being cardiac cath. And the most common organism implicated is Staphylococcus epidermidis. Now, we divide these, we stratify them into early and late. So if it occurs within 60 days of valve replacement, you can say most likely the infection is acquired during surgery or via contamination of intravenous cannula. If the infection occurs more than 60 days after surgery, it's likely another valve endocarditis. How do we make the selection of a particular valve? Well, if we're dealing with a younger patient who has no contraindications to anticoagulation, then a metallic valve prosthesis is preferred. But among the elderly, or if indeed there is a contraindication to anticoagulation, tissue valve prosthesis is preferred. Now, if your patient has atrial fibrillation, what prosthesis is preferred if you want to replace that valve? You don't have to go metallic, because remember that all patients who have atrial fibrillation, who have structural heart disease, require anticoagulation with warfarin. Which prosthesis is used among women of childbearing age? Well, let's talk about it. Regarding the tissue valve, it's preferable in pregnancy as no anticoagulation is necessary. However, valve degradation occurs at about an incidence of about 50% at 10 years and 90% at 15 years. So you're probably going to have to replace that tissue valve later on. The advantage of the metallic valve, it has excellent durability, but does mandate lifelong anticoagulation with warfarin. As we know, pregnancy itself is a hypercoagulable state due to increased levels of fibrinogen and factors 7, 8, and 10, as well as diminished activity of your protein S, together with the state of venous hypertension and the stasis. So a metallic valve is not preferred in this scenario. Remember also, if you use a metallic valve, you've got to anticoagulate with warfarin. The problem about warfarin in pregnancy is that it crosses the placenta and is associated with a 5 to 12% chance of embryopathy during the first trimester. So it's highly teratogenic, as well as, not to mention, the anticoagulant effect on the fetus, which can predispose to spontaneous fetal intracranial hemorrhage. All right, back to our clinical case, guys. 27-year-old ex-IV drug user who's now clean has evidence of severe mitral regurgitation, both clinically and on echo. He has normal LV systolic function. What you going to do? Where you going to go? How you going to manage? Let's talk. Surgical mitral valve repair is the way to go here. We know that surgery for chronic severe primary mitral regurgitation is indicated once symptoms occur. So once he gets the dyspnea, the diminished effort tolerance, you want to intervene. Valve repair is preferable over valve replacement wherever feasible. Surgery is also recommended if your patient was asymptomatic but has LV dysfunction characterized by a left ventricular ejection fraction below 60% and a left ventricular end systolic dimension exceeding 40 millimeters. Beloved, the Bible tells us that God is love. Yes, God is holy, And God is also love. And if we are made in the image of God, we should also be abounding in love. This is what Paul encourages the Philippians with in the book of Philippians chapter 1, verses 9 through 11. He says, "This is my prayer for you, that your love may do what? May abound more and more in knowledge and depth of insight, so that you may be able to discern what is best and to remain pure and blameless until the return of Christ, being filled with the fruit of righteousness that comes from Jesus to the glory and honor of God." Beloved, indeed, Jesus is coming back. He's coming back for those who are awaiting him. He's coming back for his faithful. And I pray that we will be filled with the love of God in our conversation, in our interaction, in whatsoever we do. The love of God will flow through us. Have yourself a wonderful day. I'll see you soon with another video on this channel. God bless you.